This is Chapter 27, The Child with Cerebral Dysfunction, Part 3. So how do kids get a head trauma or cerebral trauma? Well, falling from trees, fences, whatever. Motor vehicle injuries, this can be being a passenger or being hit by a car. Bike injuries. These sort of traumas occur more in boys than in girls. If it's an infant, you really need to think about the possibility of shaken baby syndrome. So the pathophysiology of a head injury is different between an adult and a child. The reason kids get these is they have a really large head compared to their body size, and they have relatively weak muscles through the neck. It's also why shaken baby syndrome is so bad. You shake the body a little bit, and the head, with those weak muscles and the big heavy head, flops back and forth much more dramatically than the body. With that increased scalp area, we get increased bleeding. And again, the back and forth movement, the brain inside is shifting back and forth, which increases the possibility of shearing. And our worst thing that causes these is sudden deceleration. So you're falling and you hit something solid and that acceleration suddenly stops. Here's a picture showing what happens, right? So your head is falling and it comes to a sudden stop. The brain keeps going and bangs here, and then it bounces off and bangs back here. So we call this the coup and the counter coup. As the brain shifts, we can tear vessels, both outside and inside the dura. As the brain shifts, it moves across the base of the skull, which has some fairly rough areas that cause shearing along here. So all of those can be significant problems. What happens, we get this injury from compression, squeezing the brain, or tearing or shearing. The coup is where the accident happens, the part of the head that hits. The counter coup is the opposite, from the brain bouncing back and hitting somewhere else. We said the sudden deceleration is the biggest problem. The shearing, we said, is where it rubs against parts of the skull that have stopped moving and the brain's still moving. And if there's enough pressure or pushes hard enough on the brain, we can get herniation, which is the brainstem pushing down through the tentorium. And this is life-threatening. The brainstem pushes down through that opening where the spinal cord is with all the blood vessels and the nerves, and you pinch off the blood supply to the brain. So this is death within minutes. This is kind of another picture showing what kids do, how they bang their heads. And again, the coup and the counter coup, and the vessels that tear and the shearing. So let's talk about some of the different terms that we use with head injuries. Concussion. This is a traumatically induced alteration in mental status. These are the most common head injuries. Probably, many of us have had a concussion. They are transient and reversible. So they're temporary and they leave no permanent problems. The most common symptoms are confusion and then amnesia of the event. Vomiting, nausea are common as well. Loss of consciousness is not necessary, can happen, but it's not necessary. But most of the time, the person does not remember when they actually fell or the actual event. Now, a contusion has very similar symptoms to a concussion, the difference being we can see it on a CT scan because there's actual bruising of the cerebral tissue. Where concussion, the CT scan looks normal. When we have contusions, again on infants, we've got to consider shaken baby syndrome. A laceration, we've actually torn the dura that surrounds the brain. And this can happen when there's a penetrating wound, so something went through the skull and punctured the dura, or there's a skull fracture and a piece of that fractured skull punctures the dura. Skull fractures actually happen less in infants and children than in adults, just because their bones are a little more flexible. They aren't as solid yet. When they do get skull fractures, they tend to be basilar skull fractures, and those are our most severe kind. So a skull fracture can cause severe brain damage or absolutely no brain damage, just depends. It can cause hemorrhages because you can tear vessels. The book just gives us some different types. Linear skull fracture is just a single line of the fracture. A depressed or dented skull fracture means a piece is actually pushed down, and that is where we worry about the dura being torn. And then a comminuted fracture, that comminuted usually means there's multiple pieces. So this is one where there are multiple fractures that are all associated. So it's not that they're separate fractures, they're from the same spot, but it kind of fractured out in different directions. And then the base of the skull, the basilar skull fracture, and those are the ones that happen the most often with kids. They're also the most severe. So this is breaking a bone, frontal, ethmoid, sphenoid, temporal, or occipital. So this is kind of that bottom of the skull. Depending on where it's broken, you can get the battle sign, which is that bruising behind the ear that you see in the top picture, or raccoon eyes, like you see in the bottom picture. These high risk of breaking that dura so that you get some CSF leaking. So we're going to look at the nose and the ears for CSF fluid. If we do have CSF fluid, we're going to use prophylactic antibiotics because there's such a high risk of meningitis. We have a direct route in there into the brain. And then you're also going to be looking for associated nerve injuries. Our book has several nursing alerts in this chapter. If a child has a head injury, stabilize the spine until either we rule in or rule out a spinal cord injury. And if a child has a head injury, a facial trauma, we are not going to put an NG or a suction catheter through the nose because we can cause secondary infection or put it through the fracture and right into the brain. Also, if we get bleeding from the nose or the ears, which is not common in children, that needs further evaluation. And if we get a watery discharge from the nose, we are going to test it for glucose. And if it does have glucose, it's most likely CSF. So now we have torn dura and high risk for meningitis. So complications of head injuries: hemorrhage, infection, edema, and herniation. So hemorrhage, we're worried about epidural or subdural hematomas. So epidural is outside the dura but under the skull. This can still be severe, can push on the brain to the point that we herniate, which can kill you, or it can be subdural, below that dura, so between the dura and the cerebral tissue. And again, this can push until it herniates and kills you. So an epidural, we said it's between the dura and the skull, but it's going to have enough force that it's pushing on the brain. Just based on what usually tears in this area, this is usually an arterial bleed. So the bleeding is kind of minimal until the pressure builds up and then it suddenly gives. So usually this child seems fine right after the accident. They have a short period of being lucid and then all of a sudden they deteriorate quickly. They say that lucid time, the symptom-free time, can be as much as 48 hours. It's usually not, but it can be. So this is more of an issue kind of teenage, not as common in children. With kids and infants, we see more subdural hemorrhage. So this is under the dura and against the cerebrum. And this is usually the cortical vein, so it's usually venous. So it develops a little more slowly, and it's just more of a thin spread. But remember, blood against your brain irritates the brain, and now we can get some swelling of the brain tissue and get that cerebral edema. So this is actually a birth trauma that can happen. And with kids who have this, prognosis really varies, can be poor. You can have developmental delays and failure to thrive with it. In an infant, they can do a subdural tap, so they can actually put a needle down into that subdural space and draw it out. In older children, where the sutures, the fontanelles are all closed, they're going to have to surgically go in and evacuate this. So cerebral edema, we said, is also an issue. Anything that is injured swells, and that swelling usually peaks somewhere between 24 and 72 hours. So that's true of cerebral edema. We're worried that it can get worse for up to 72 hours. And as that swelling increases, our intracranial pressure increases, which can cause vascular stasis, anoxia, and that anoxia, it's going to cause increased CO2 and further vasodilation, which is going to make the intracranial pressure worse. If our intracranial pressure exceeds our blood pressure, that's when we're not going to get any blood flow to our brain, or if it gets bad enough, that intracranial pressure can cause that tentorial herniation. So in a head trauma, ABCS, we're going to always be checking for airway, breathing, circulation, and then maintaining the spine. We're going to probably get skull x-rays. We are not going to do an LP because sudden changes in the CSF fluid can make sudden changes in the brain and shift everything around and tear vessels, cause shearing. I mean, we don't want to do that. So an infant, again, remember, we have open fontanelles and sutures. If there is something in there, they can go in and take it out that way. And then we said watery discharge, we're going to do a dipstick, just like we use for urine, to look for the glucose to see if that could be CSF fluid. So we already said some of these. ABC, S. So we're going to do our ABCs plus stabilize the spine. This is probably an accident, so clean abrasions with soap and water. Make this child NPO. We don't know what's coming next, right? Check the level of consciousness. And if they go home, if this is fairly mild and we send them home, we're going to tell the family to check their level of consciousness and their pupils at least twice during the night. They need to set an alarm and get up. We don't want the parent sleeping for hours, because if there's a change, we don't want to go 6 hours or 8 hours without catching it. So check them at least twice during the night. If this child needs to be hospitalized, well, if there are severe injuries or they've lost consciousness for more than just a brief time, then we want them hospitalized. Or if they've had seizures, we want to hospitalize them. I put on a couple of links here if you're curious about seeing epidural and subdural hematomas. These are both surgeries where they are evacuating them. So moving on to submersion injury. We used to call this near drowning. Now we're calling it submersion injury. This is a major cause of death for children. Most often it's under age 4. And if you think about it, infants, usually it's in a bathtub. Toddlers, with their big head, they lean over and look in and fall into a bucket or a toilet, and then they can't get themselves out. Preschoolers, it tends to be swimming pools. Older kids, it tends to be natural bodies of water, lakes and rivers and things, because kids are really curious about water. And our big problems are hypoxia, aspiration, and hypothermia. Kids will get a decrease in their body temperature, but our concerns are the brain and not getting blood and oxygen to the brain, and then the lungs. If they have aspiration, can cause us problems even a little while later.